Dr. Kimberly Larson-Ohlsen. I am board certified in OBGYN. I am a fellow in integrative medicine, and I'm a certified acupuncturist. I've been in the community since 2001, since I finished my residency. I was an associate professor at the University of Colorado. I was in private practice, and currently I work for Colorado Complete Health for Women. Prior to being a physician, I was a teacher. I taught first grade, third grade, and college. And I truly feel that my purpose in life is to be a healer. I look at myself as a modern-day medicine woman, and I love empowering women and educating them on their journey to health and wellness. So today, I'd like to talk about a solution to women's intimacy. I'll give you a little bit of background, we'll come up with some treatment options, and I'll specifically talk about the MonaLisa Touch. So do you have vaginal dryness, burning, itching, pain with intercourse? Do you feel like you have to urinate all the time? Do you have frequent urinary tract infections, recurrent vaginal infections, vaginal irritation, or discomfort? Then you may have a condition called vulval vaginal atrophy, or VVA. It's also called urogenital atrophy. You may hear atrophic vaginitis. And the new term is genitourinary syndrome of menopause. And it really is due to a decrease in estrogen. But unlike other symptoms that are due to a low estrogen state, like hot flashes and night sweats, vaginal and vulvar symptoms get worse with time, and they progress. And they really affect a woman's sexual health and well-being. But the good news is you're not alone. 32 million women suffer from this condition. 50% of women over the age of 60 have one or more symptoms of vulval vaginal atrophy. And 50 to 75% of women with breast cancer have one or more symptom and are at significant risk for severe vulval vaginal atrophy. And only 2.3 million women are currently being treated. But it's not just for older women. Obviously, if you've undergone natural menopause, you may have symptoms, but women who have had surgical menopause with the removal of their ovaries, with or without a hysterectomy, may have symptoms. Women who have undergone premature ovarian failure, so before the age of 40, their ovaries quit working. Perimenopausal patients, who especially have issues with urinary incontinence when they jump on a trampoline or go running, and pain with intercourse. Women who take certain types of medication to treat fibroids or endometriosis, chemotherapy or endocrine therapy, prolonged breastfeeding, women who don't have periods because of excessive exercise or an eating disorder, smokers, women who've never been pregnant. And even if you're taking systemic estrogen, 25% of these women experience symptoms. And 10 to 20% of women using vaginal therapy also may have vulval vaginal atrophy. Well, what else could it be? It could be an infection, vaginal bacterial vaginosis or yeast infection. It could be an irritant, kind of a contact dermatitis with a douche or a lotion. It could also be a skin condition, eczema, like lichen sclerosis, or even vulvar cancer. It could be a pain syndrome, vulvodynia or vagismus. It can also be a medical condition, something like diabetes or lupus, trauma or a foreign body, some type of psychological issue. So it's really important that you see your practitioner, or me, to get thoroughly evaluated and to get a complete diagnosis before we begin treatment. So I wanted you to see what the vagina and the vulva look like with estrogen and without estrogen. Estrogen is the dominant hormone in vaginal physiology. And with adequate estrogen, after puberty and before menopause, the vagina is characterized by these really rich, thick folds called rugae that stretch with intercourse. There's lots of blood vessels and glands that make adequate secretion so there's not as much pain with intercourse. But after menopause, there's a decrease in estrogen. The vagina narrows and shortens. There's a decrease in the elasticity. Those rugal folds go away. The glands decrease their secretions, and oftentimes that's the first symptom that women complain of, diminished or delayed lubrication with intercourse. And this tissue is really susceptible to trauma, so there can be tears, bleeding, and some women get some yellow discharge. So remember, I was a teacher, so I want to take you back to histology. The first slide here shows a slide of the vaginal tissue with adequate estrogen. That top layer is the epithelium. It's nice and thick. It has something called glycogen in it that allows for the bacteria in the vagina to allow for no infections. And the bottom part there has lots of collagen, elastic tissue, and blood vessels. So it really stretches with any type of intercourse. The next slide there is low estrogen. You can see that that top layer is really thin. The bottom layer there is really only connective tissue. So there's really no movement. So then I get the question, do I need it to be treated? So treatment is indicated if symptoms affect a woman's health and well-being and activities of daily living. There may be a situation where your practitioner wants you to be treated without any symptoms. Those include a vulvovaginal surgery, where you may undergo a hysterectomy or a bladder lift. And that's to help the practitioner see the tissue planes and possibly to help healing. Many practitioners use it for pelvic relaxation or prolapse, when the cervix or the bladder or the rectum are coming down or out the vagina. And it's particularly important to use with a pessary to prevent any type of ulceration or laceration. And then there's my favorite concept, proactive education. Should we be having conversations with our practitioner about potential changes to the vagina in a low estrogen state? Should we be discussing frequent intercourse, using a vaginal moisturizer, trying the MonaLisa Touch before the changes actually occur? First line treatments. So the goal of treatment is to alleviate symptoms. And many practitioners go in a stepwise fashion because it's often long-term. Vaginal moisturizers do work for mild symptoms. They decrease the pH of the vagina and work like a buffer. They attach to the vaginal wall and increase water. But they are turned over by cell turnover, so women need to know that they might have an increase in discharge. Now, they do decrease friction and pain with intercourse, but they're not going to change any of the vaginal changes that occur due to that low estrogen state. Examples of vaginal moisturizers include Replens, Yes VM, Vagisil, and you can see them all listed there. The last two, Luvena and Lubriderm, they're both vaginal moisturizers and vaginal lubricants. Now, vaginal moisturizers need to be used every 3 days, probably for the rest of your life, not just with intercourse. In addition to any of the treatments that I talk about today, you really should use a vaginal lubricant with intercourse. It will decrease friction and irritation. There are water-based lubricants, which are easy to use, easy to clean up. There are silicone-based lubricants that last longer and are hypoallergenic. Now, both the water-based lubricant and the silicone lubricant can be used with condoms and with most toys, but you don't want to use a silicone-based lubricant with a silicone toy. There are oil-based lubricants. They tend to be a little messy, and you cannot use them with condoms. Examples of water-soluble products are listed. My favorite of that whole list is Astroglide Naturals and Good Clean Love. The next slide shows examples of silicone-based lubricants. Again, here you can read all of the different brands, but my favorite ones are Uberlube and Perdure EOS. If indeed you want to use an oil-based lubricant, you can. Coconut oil is the best, but really try to avoid Vaseline or petroleum jelly because it does increase infection. Then there's the whole concept of use it or lose it, kind of a mechanical stimulation. There are studies that show that women who are sexually active, either through masturbation or intercourse, 1 to 2 times a week have a decrease in vulvovaginal atrophy. We think it's due to the stretching of the vagina and the increase in blood flow, but the actual timing and amount is really patient-specific. Women who can't use estrogen, we really discuss things like vaginal dilators, a pelvic physical therapist, and then I'll get to my MonaLisa Touch. Vaginal estrogen therapy is a wonderful modality for moderate to severe vulvovaginal atrophy. In the presence of adequate estrogen levels, normal pH returns, normal bacteria, there's that thickening of the vaginal tissue and the return of the rugal folds, so it stretches with intercourse. Vaginal secretions increase, so there's a decreased pain with intercourse. There's a decrease in infection, urinary tract infections, and overactive bladder. There are numerous types of vaginal preparations. 17-beta estradiol is bioidentical. That's what your body is used to seeing. That comes in a cream, in a tablet, or a ring. Then there's conjugated estrogen, Premarin. That's over 200 different compounds that your body has never seen. It's made from horse's urine. There's estrogens, progesterones, and androgens. And finally, there's estriol. Many naturopaths and other physicians think that it's probably a better alternative because it's a weaker estrogen and possibly less carcinogenic. It comes in a cream, a suppository, or a pessary, and you do have to get it at a compounding pharmacist. It really depends on the patient, but in about 3 weeks, most women see a significant decrease in their symptoms. But some women will take up to 4 to 6 weeks. Now, the concern that many women have is the potential risk of vaginal estrogen, and we really don't have good long-term studies. We do know by our ultrasensitive assays that some estrogen is absorbed and found in the serum, but we don't know if that equates to an increased risk in endometrial cancer or uterine cancer or breast cancer. And I think if it did, we really should see that effect by now. The next slide really shows how much it costs if you did not have insurance or if insurance doesn't pay for estrogen. And unfortunately, now many insurances, especially Medicare, are not paying for vaginal estrogen. So if you look at the chart there, the cheapest one that you could get would be at Target. So at Target, you could get Premarin for $188 a month, but that's still $2,256 a year. And if you wanted Vagifem, which are the tablets, and you went to Walgreens, that could be $1,000 a month. So $12,000 a year. Well, so then a lot of people are like, how long do I need to be treated? And treatment is really individualized. However, when we do stop treatment, the symptoms come back. And again, clinical trials haven't gone beyond a year. There is a Cochrane review that looked at 19 randomized controlled studies of over 4,000 postmenopausal women, and they found that rings or tablets or creams are equally effective at treating vulvovaginal atrophy. So it really comes down to cost, preparation, patient choice that should guide your choice. And obviously we want to use the lowest dose at the lowest frequency. And oftentimes we start with something called a therapeutic treatment, where we do treatment every night for 2 weeks, and then we try to drop it down to 2 to 3 times a week. And we really want to avoid using it 12 hours before intercourse to avoid any type of absorption by your partner. But a lot of women don't like local estrogen because they might get a yeast infection, some type of vaginal irritation, vaginal bleeding, or breast tenderness. And many women don't like the messiness of the cream. They have to use an applicator, they pull it back to a certain line, they have to go to the bathroom, lay down, put the applicator in, get back up, disassemble the applicator, wash it out, and let it dry. So adherence is very variable, anywhere from 52 to 74%. And then there's an oral medication called Osphena. Osphena is a selective estrogen receptor modulator. It acts as an estrogen in some tissues and an anti-estrogen in other tissues. It is FDA approved for the treatment of severe pain with intercourse due to vaginal atrophy. Some people really like it because they don't want to use a vaginal preparation. They're either morbidly obese or they have severe arthritis or some type of pain syndrome. Potential side effects or risks are that it increases hot flashes and deep venous thrombosis, which are clots. Now my favorite part, non-surgical female rejuvenation procedures. There are CO2 lasers, there are non-ablative lasers, there are monopolar frequency devices, there's hyaluronic acid fillers or fat fillers. Many of you have probably heard about the O shot, and that's where they take your blood, spin it down, use the platelets, and then they re-inject the vagina with those platelets in this place called the Grafenberg spot or the G spot. There's really no good data. So the MonaLisa Touch is a fractional CO2 laser that allows your body to use its own innate healing to rejuvenate vaginal tissue. It leads to vaginal revitalization and rejuvenation. It's not a surgery. It's painless. It's done as an outpatient in my office, and there's no need for any anesthesia, although we may use a little bit of topical lidocaine. A probe is placed into the vagina, and a handpiece is used on the vulva. And through the transfer of light and the generation of heat, new tissue is formed. New collagen, elastic, and blood vessels. Now, this new generation of tissue essentially bypasses the need for any type of topical preparation, such as moisturizers or vaginal estrogen. There's the return of that thick tissue, those rugal folds, increase in secretions, so it decreases pain with intercourse, vaginal infections, vaginal dryness, urinary tract infections, and overactive bladder. Essentially, the vagina is returned to when you're 18 or a premenopausal state. Remember, we also treat the outside of the vagina, and that's really to help with that sandpaper fill that many women experience with the initial penetration with intercourse. Also, we treat the clitoris and the clitoral hood. I have many patients tell me that their libido's improved and that they now have orgasms. The MonaLisa Touch has been found to increase or improve sexual function, receptivity, and initiation. It's a 5-minute procedure. There are 3 treatments, 4 to 6 weeks apart, and then 1 annual maintenance therapy. People have told me it is life-changing. And the next slide shows tissue of what the vaginal tissue, what it looks like after you've had a MonaLisa treatment. And those little white areas are just the little ablative regions. Again, this is the same patient. The first slide here, you can see that there are no rugal folds. It's completely flat. There's no secretions. The area that's circled is petechiae, and that's actually trauma. But again, they took this next slide is that same patient. Increase in those rugal folds, lots and lots of secretions. So I'm going to take you back to histology. First slide, really low estrogen, no connective tissue or blood vessels. Second slide, really thick epithelium, lots of collagen, blood vessels, and elastic tissue. So the only downtime is about 3 to 5 days, and about 10% of the women experience a little bit of vaginal discharge or some mild spotting. There are only a few women who can't have this treatment. So if you have an active infection, like herpes, now we can treat you if you have herpes. We just need to give you medication so it suppresses it, so you don't actually have an active lesion when you come in for your treatment. Someone who has a lesion on the outside of the vagina, again, that's the vulva, inside the vagina or on the cervix, that hasn't been evaluated. If you're pregnant or 3 months postpartum, but I have treated women who have using prolonged breastfeeding because that's a low estrogen state and it's worked really well. Women who have pelvic relaxation where it's actually coming down or out the vagina, but again, women with moderate to mild pelvic prolapse, phenomenal results. If you have had a surgery with mesh, we try to avoid using it. Now, you can have had a bladder lift, but if you've had a surgery with extensive mesh with an anterior or posterior, just parts of the vagina repair, we kind of want to avoid it. And then if you've had any radiation to your pelvis or your colon, and women then who have issues with overactive healing called keloids or poor wound healing. But I didn't want you to just take my word for it. I wanted you to look at what the data shows. So the first study here is out of Italy. There are 50 women, average age is 59.6. And they looked at both subjective data, how did it make you feel? Did it decrease pain with intercourse? Was there a decrease in dryness? And then they looked at objective data. They looked at pH and moisture. And they found an 82% satisfaction and an improvement in all the vaginal health parameters. And the only complaint was a little bit of discomfort with the first insertion of the vaginal probe. The second study here is 77 women, and of those 77 women, 57 were able to have intercourse, but 20 were not. After one laser treatment, 17 could have intercourse. So that's an 85% could have intercourse. And then they found improvements in all the vaginal health parameters also. And there were no adverse side effects in either one of these studies. I really started to look at the MonaLisa Touch for my breast cancer survivors. I tried vaginal moisturizers, we tried pelvic physical therapists and dilators, but I really didn't seem like I was getting an adequate effect. So that's really why I started looking for the MonaLisa Touch. So the next study here is specifically for breast cancer survivors. The average age is a little bit younger, it's 53.3, and they found a 76% satisfaction at 3 months, and that was maintained. The next study in the next slide isn't really new anymore. It's from 2016, but it's a pilot study. And what a pilot study does is it looks to see if this technology is effective and should more money be placed and looked at further research. And they did find that indeed it was. They used 30 women and they had a 92% satisfaction. There is nothing that I do in medicine that has that high of a satisfaction rate. They noticed improvement in all of the symptoms that they looked at 3 months, and that improvement was maintained at 12 months. There was a decrease in vaginal dryness, pain with intercourse, and improved sexual function. Again, no adverse effects, but about 10% of those women had some vaginal discharge and spotting, and they could not even use lubricants when they had intercourse. So that's the good news. The not so good news is it's not covered by insurance. Currently at my practice, it costs $2,100 for 3 treatments, and then you want an annual maintenance therapy for $700. Then to be complete, since I am an integrative physician, I wanted to touch on complementary therapies. There are some studies on vitamin D, vitamin E, phytoestrogens like soy, red clover, and hops, DHEA, testosterone, and then there are naturopathic or homeopathic remedies. The study on vitamin D looked at 60 women, 30 that took vitamin D and 30 that didn't. They looked at symptoms, and then they also looked at something called the vaginal maturation index, where they looked at superficial cells versus basal cells. And if you have more superficial cells, it means you have improved vaginal health. And they found that both groups had essentially the same symptoms, but those that took vitamin D had an improved vaginal maturation index. So what does that mean? Maybe vitamin D can be used or something like that to treat vaginal atrophy. Many women have used vitamin E in the past to decrease irritation and symptoms of vulval vaginal atrophy. You can take it both orally, 100 to 600 IUs a day, or use it vaginally. There are many studies out there on phytoestrogens. There's a study on red clover, which uses 40 milligrams of red clover daily for 8 weeks. And they looked at the uterus to make sure that the uterine lining wasn't increased. And we think if it's not, that it equates to not an increased risk in uterine cancer, but we're not 100% sure. But it did not increase the lining or the thickness in the uterus, and it did improve all vaginal health symptoms. Then the hot new topic is DHEA, interosseous or progesterone. There was a randomized controlled study last year that was in a 1-to-3 ratio. So there was 157 patients in the placebo arm and 325 patients in the treatment arm. They looked at 0.5% or 6.5 milligrams of DHEA in an ovule that was placed in the vagina every day for 12 weeks. They looked at those superficial cells and those basal cells. They looked at pH, and then they looked at pain with intercourse. The authors found a significant effect in all the parameters that they were looking at. But what's really interesting about this study is there's no post-treatment data table. There is graphical analysis, but when it comes to pain with intercourse, the numbers are so close that I'm afraid they might be overrepresenting their data. So it's biologically plausible that it really may work. I just want to see more data and long-term follow-up before I implement it in my practice. Then there's testosterone. There's a study last year that looked at 1 gram of estrogen versus 1 gram of testosterone versus a vaginal moisturizer versus just KY jelly. They had 20 patients in each arm. Again, they looked at those same parameters. They found that both estrogen and testosterone decreased the pH, but only estrogen improved the vaginal maturation index. So the authors thought maybe they didn't go long enough or it was the wrong dose of testosterone. Again, it's very plausible that testosterone will work. There are androgen receptors, especially on the outside of the vagina called the vulva, but I just need more data. And finally, there are lots of natural or homeopathic remedies. People use nettle, comfort root, dong quai, and belladonna. And finally, there's still lots of questions. Should we use these synergistically, in combination, or sequentially? And what works for you might not work for you. And what worked for you in your 40s might not work for you in your 60s. So what I suggest is that you have a lifelong relationship with your physician on your journey to health and wellness.